بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم and welcome everyone to the third day of Fundamentals of Clinical Research and course. This course is organized by College of Medicine at Al-Imam Mohammed bin Saud Islamic University. Before we start, just ندعو لوالدنا خادم الحرمين الشريفين الملك سلمان وأمير الكويت جابر صباح جابر أحمد الصباح أنهم يشافيهم ويعافيهم ونفرح بخروجهم من المستشفى قريبا بإذن الله. I'm your moderator today. My name is Yusuf Khoja. I'm assistant professor and consultant orthopedic surgeon at College of Medicine, Imam University. Our guest today is Prof. Mustafa Abul Futuh. He is professor and senior research scientist at King Abdullah International Medical Research Center and King Saud bin Abdulaziz University for Health Sciences and Ministry of National Guard Health Affairs. Prof. Mustafa, he is also professor of family medicine in High Institute of Public Health, Alexandria University in Egypt. And he is WHO and EMR expert in the School of Health Science. He used to work as professor of family and community medicine at King Saud University, Abha branch. And after it changed its name to King Khalid University from 1990 to 2000. His educational background, he has doctorate degree in family health from Alexandria University. And he has a diploma of child health from Glasgow. And he has fellowship of American School of Health Association in 2000. Prof. Abu Futuh, he is an author of more than 230 publication in peer review journals. He wrote many books and many chapters in different books. And one of the key books he participated in writing it is Research Method Made Easy, which you can find it on the Amazon website. His area of expertise is child and adolescent health, more than 30 years, and a behavioral social scientist. He has experience as family and population and community health specialist. He is expert in SPSS, EBO-Info, and Graph, PRISM, and StatCalc. Today, he will share and talk about types of research studies, how to choose the appropriate study and design for your project. Before we start this housekeeping comments, first of all, all participants are in attending mode. You cannot share or speak during the presentation. If you have any question, you can share your question or ask your question in the Q&A section. If you wish to speak out, there is 20 minutes at the end of the presentation. If you want to ask your question by your voice, you can raise your hand and we will unmute you to ask your question. Other way, you can ask your question through the Q&A section. Without further ado, the screen is for you, Prof. Abu Futuh. Go ahead.
Thank you, Dr. Yusuf, for your introduction. And I would like to thank Dr. Hassan for inviting me for these very special events. And this is the first time for me to be invited by Al-Imam University. Although I used to have lots of many of the students, of the medical students during the summer in our research summer school in the KMARC. And we are happy with that actually. And lots of many of those students know me well and participate with me in writing many of their publications actually. So I hope this 2 hours will be beneficial for all participants, whether students or doctors or academicians. I will try to simplify it as much as I can. The topic of this lecture or presentation is actually about research design, and this is a very important topic because without knowing of what is the appropriate research design to choose for your research to achieve your objectives, it will be impossible to have a paper that is acceptable for publication in a reputable journal. This is very important. So I will try to first to simplify things. Let us agree that in order many or more than 90% of our studies deal with finding the association between one exposure or more than one exposure with a certain disease or outcome. It is not necessary to be a disease. It might be a disease or disability or discomfort or whatever, or dissatisfaction, the 5 Ds, you know. So it's an exposure and outcome relationship. This is actually the hypothesis in our research, which is usually a causal hypothesis. Whether there is an association between, for example, smoking and cancer, its exposure will be the smoking and the cancer will be the outcome. Whether there is an association between dietary habits and obesity, dietary habits will be the exposure variable and the outcome will be the obesity or diabetes or whatever. So we must have at least one variable, one exposure variable and one outcome variable at least. But we will know that we have to include many other variables as confounding variables, as you will see maybe by the end of this lecture. So, the question, this is a research question. Are exposure and disease linked? This is very important. Okay, so research designs will be chosen based on some items. First of all, what is the research question? What is the objective? What is your objective of study? Is the objective to estimate the prevalence of a certain condition like diabetes or hypertension? If so, it means that the objective is estimation of the prevalence. So you must choose what is called a prevalence study, which is a cross-section study, a prevalence study. If your objective is to estimate, for example, or to identify the incidence of complication of MI, of myocardial infarction, so you must choose what is called an incidence study, which is the cohort study, whether a retrospective cohort or a prospective cohort. So it's an incidence study. Okay, if your objective is to identify the risk factors of diabetic foot, for example, so the ideal research design will be a case control study. Case control study is an ideal study for identification of or identifying the risk factors for a certain condition or a disease. Okay, if your objective is, for example, to assess the impact of a certain intervention, so you must choose one of the interventional designs. We have many interventional designs to deal with. If you have time, we'll discuss them more. So this is regarding the research object. The time available for the study. If you have sufficient time, you can do what is called a prospective study. But if you don't have that time, you must choose a study that is a retrospective one, retrospective study. And the ideal retrospective study will be the case control study, as you will see later. Okay, so the time is important. Resources, if you have sufficient resources, suppose you are doing a research survey or a community survey to identify the concern or the attitude of the public towards COVID-19, for example. So you will need many of the data collectors, trained data collectors, to fill the questionnaires or to do interviews with participants. If you don't have these data collectors, it will not be feasible to do your study. Whether the disease is common or rare, or the exposure is common or rare, as you will see, when the disease is rare, we must use what is called cohort study. But if the exposure is rare, if the exposure is rare, we use a cohort study. If the disease is rare, you use what is called case control study. You will know better after a few minutes about these. Types of outcome of interest. If you have multiple outcomes, you are interested in multiple outcomes. Outcome, for example, of delivery, of teenage pregnancy, for example, like fetal outcome, maternal outcome, the most appropriate design will be the cohort study, because in cohort study, it will be possible for you to identify many of the outcomes, not only one outcome. Quality of data also is very important. Quality of record. If you have quality records, you can rely only upon the records and data available in records to do your research. And we conducted many of our studies, and we have them published in reputable journals, and we relied mainly on record to collect our data. So this is, for example, this is an example of the questions or research questions to by which you determine the appropriate research design. Do mobile phones cause depression? So it's a causal relation. You can do a case control study, for example, to see whether mobile phones are considered, use of mobile phone is a risk factor for depression. You can use a group of depressed people and another group of non-depressed and ask them about the history and duration and the onset of using mobile phones. So by this question, we can decide which design to choose. How much exercise should I take? It can be done in a cohort study or in an intervention study. I can I can select a group and assign them for certain exercise, and another group are left without this exercise, for example. And you see the outcome after 3 or 6 months, for example, for the outcome in terms of fitness or some measures to assess the fitness of the participant. So we can do that for example, or in a prospective study, for example, cohort study, you can select a group who are already on exercise and another group not non-exercisers, and we follow both groups up to see the outcome of both groups in terms of cardiac rate and hypertension or whatever. You see, should I take a statin? This is very important, statin for lipid lowering, which is lipid lowering drug, for example. We can investigate the association between statin and lowering lipids, for example, blood lipids, for example, and the cardiac attacks, for example, among or readmissions among patients with cardiac problems. What is the best treatment for breast cancer? We can apply many of the modalities, 3 or 4 modalities for breast cancer, and see the outcome in either a cohort study or in a clinical trial. How many people suffer from depression? So it's a prevalence. We are interested now to estimating the prevalence of depression. So the best study design will be the prevalence study, which is a cross-section study. So this is a way to choose the study question or the study objective is the main determinant for identifying the type of study too. Is coffee drinking good or bad for health? So it's a good question also. So many of the studies, for example, investigated the association between, for example, coffee drinking and coronary artery disease. And surprisingly, they found a strong association between coffee drinking and heart disease. But they discovered after that there were some confounders for this association that distorted this association. And when they adjusted for this confounding variable, the association between coffee drinking and coronary artery disease disappeared. So we must include the confounders, all possible confounders or confounding variables in our study. Otherwise, it will be a problematic when submitting our paper or our study for publishing. So let us now agree that we have two groups of study design, observational and intervention. What is the difference between observation and intervention? Observation means we observe, we only observe. We do nothing except observation. You see, observe, we do not intervene. We do not add something, just intervene, just observation. But in intervention, we do something. And to be more clear, for example, the E&D association, this is the causal hypothesis, is the E&D association, right? Or exposure and outcome association, which is mainly our aim in all of our studies. In observational, we select people with the exposure, like smokers, for example. But in intervention, the exposure is given by us, is assigned by us. This is the difference, but it's the same, E&D association. So what is the difference between observational and intervention? In interventional, the exposure is assigned by us. The exposure is assigned to the exposure group by us. But in observational, the exposure is there, is already there. Like in smoking, for example, we can't assign smoking some people to smoke, for example. That's why up till now, we have no intervention study to assess the relation between smoking and cancer, for example. That's why the tobacco companies are lucky, because up till now, there is no intervention study to assess this association. All studies are observational. And the gold standard for decision is intervention, actually. So as we are not able to, up till now, to do intervention study, we can't make a decision to abstain from smoking by the companies. So the two types are observational, for which we observe, and the experimental or intervention. Okay. Again, we can subdivide the observational into descriptive studies and analytical studies. What is the difference between descriptive and analytical? In descriptive studies, we describe the distribution of a disease or condition in terms of time, place, and person. That's it. In what place, what persons are affected, in which time, whether there is a seasonal variation, this is a secular trend or whatever. In which place, for example, when we say, for example, malaria is endemic in the southwestern of Saudi Arabia, for example, in Tehama region, for example, but not in Riyadh or in Jeddah, for example, something like that. In what person? In children or adults, in males or females. Some diseases are for male and some diseases are for female, either by physiology or by anatomy, right? That is very important. Place also, like in, for example, MERS-CoV, for example, it started in Saudi Arabia and then in Korea, Korean outbreak, for example, and then in the Gulf region in some places and something like that. So classification in terms of places, whether international classification or national classification or rural or urban or something like that. person in terms of hobbies, for example, in terms of like, for example, some people are immunization status, for those who are immunized are protected, more protected from infectious disease than others, something like that. Analytical studies, in analytical studies, there is what is called the hypothesis. We investigate the hypothesis, فردية, hypothesis of the association between exposure and outcome, the same. So if we have this causal hypothesis, our study will be an analytical study. If we don't have, suppose we just estimate the prevalence of diabetes in Saudi community, it is a descriptive cross-section study, and full stop. But what about if our aim is to estimate the prevalence of hypertension, for example, and its association with obesity? So now we have association means a hypothesis. So it means that it will be an analytical cross-section study. That's why cross-section study might be a descriptive one or an analytical one. Other analytical study like ecological study, cross-section study, case control study, cohort study, all these we will get to them soon in more detail. In experimental studies, we have to intervene, as I told you, but we have three main groups: RCT, randomized control trial, these are on patient; field trial, those are normal subject, but in order to assess, for example, the protective effect of a certain vaccine, and that what is being done nowadays for COVID-19. Many of the vaccines, many of the field trials are being conducted so as to test the efficacy or protective effect and safety of different vaccines for COVID-19. This is a field trial. Community trial, when you apply your study on communities, different communities. Suppose, for example, you have a community with parasite infestation and another villages, for example, with one village with parasite and another village with also parasite prevalent in parasitic infestation among children, and we need to intervene with health education for the mothers and children, for personal hygiene and so on. So we apply the health education program to one of these villages as an experimental group, experimental village, and the other group is left with only the anti-parasite. Both villages will take the anti-parasite, but one of them will be subjected to the intervention educational intervention program. And we see the impact over time, whether to see the impact of the education program. This is a simple explanation to the community trial. So as I said, observation studies are either descriptive and analytical. What is the difference between both? The hypothesis, the presence or absence of hypothesis. If there is a hypothesis, it's an analytical. If no, it is a descriptive study. Very simple. Okay. So look at this nice slide. This nice slide will differentiate, will allow us to know what is the difference between cohort study, case control study, cross-section study. These items are confusing for many of the researchers, you see, but here it's easy, you see. First of all, if we have intervention, it is an intervention. Assigned intervention, it is an experimental study, either randomized or non-randomized, because experimental studies are sometimes randomized and sometimes non-randomized, you see. Let it to be later, to be discussed later. What about observation study? Again, observations. If we have to compare between groups, it means that we have a hypothesis, sex difference, for example, those, for example, with different lifestyle, for example, and the outcome. So if no hypothesis, it is a descriptive study. If yes, it means that it is an analytical study with a hypothesis. So we have three main studies. This is very important to concentrate on. Analytical studies are either cohort or case control or cross-section studies. What is the difference between them? As I told you, the hypothesis is to investigate the association between exposure and the outcome. If we start by exposure and end up with the outcome, it means a cohort. This is a cohort study. We start by smokers, for example, a group of smokers and a group of non-smokers. waiting for the outcome in terms of coronary artery disease or cancer or whatever. It means that it is a cohort study. Why? Because we started with exposure and we're keen that the outcome has not yet occurred. This is very important. When we start by exposure, we are sure that both groups, exposure and non-exposure group, are not having the outcome, the disease under study. Right? This is very important. So, and let us discuss it later because this is very important. Case control study. In case control study, it is the reverse from its name, case. So we start by a case and return back retrograde or retrospectively to determine the possible outcome, the possible exposure, the possible exposure or risk factors of a certain condition. So we have diseased group and non-diseased group, and both of them will be investigated retrospectively, asking for possible or investigating for possible risk factors. Possible risk factors are not necessary to be collected by a questionnaire. It might be by, for example, hemoglobin level, might be hypercholesterolemia, might be presence or absence of a polyp by colonoscopy, whatever. In case control study, in retrospective study, you can do lots of invasive investigations. Some people say that it's a retrospective study. A retrospective study can adapt many of the major investigations or investigations, so invasive investigations to collect the data. It is not relying upon only a questionnaire. This is very important. Cross-section study. If cross-section study, it means that we start by the exposure and the outcome at the same point of time. This is very important. Suppose I ask a group of subjects, for example, or students, individually, each one I ask him, for example, are you a smoker? Yes or no? And then, do you suffer from cancer? Or I examine him, as I told you, it's not necessary to be a questionnaire. Collect data for each person about the status of health in terms of cancer and the status of smoking behavior, whether smoker or non-smoker. At the same point of time, it means that we don't know which started which, whether they started to smoke first and then they developed or contracted cancer, or because they contracted cancer, it doesn't bother them to start smoking now because they waited for years with no smoking and then they contracted cancer. So it's time to start smoking, right? So this means that we have no guarantee of the temporal relationship between exposure and outcome. But here, for example, supposing cohort study, in cohort study, we are sure that the exposure preceded the outcome. Why? Because we started by smokers and non-smokers, and we were sure that none of the participants in any of these groups suffer from, for example, cancer, and we waited for cancer to occur. So the temporal relationship is guaranteed here. The causal relationship is guaranteed, but here it is not, and here also it is not. Why? Because it's a retrospective study, so still we don't know what happened, whether they started to smoke before contracting cancer or not. Breast cancer and oral pills, we don't know whether they contracted breast cancer before taking the oral pills or not. Obesity and the cancer and the breast cancer, we are not sure whether they were obese before or after getting or contracting the breast cancer. Okay, this is the idea. Now, in a time frame of studies, we can sub-classify studies into retrospective and the prospective. You see, retrospective and what is the retrospective? Retrospective study is any study for which the outcome has already occurred. For example, in a case control study, we start by cases. So it means that, and the case is the outcome actually. So we started with the outcome. It means that the outcome has already occurred. Also in cross-section study, many of us sometimes do not consider cross-section study as a retrospective study. It is a retrospective study. Why? Simply because we start by the outcome and the exposure at the same time. It means that the outcome has already occurred. That's why we started with the outcome and with the exposure. But in case of, for example, cohort, we have two types of cohort. We have a retrospective cohort from records, and we have a prospective cohort. In prospective cohort, we are waiting for the outcome. So it's a prospective study. But in the retrospective cohort, both exposure and outcome are available in the record. You see, that's it. So it is a retrospective because the outcome has already occurred. In clinical trial, it's a prospective study also. Why? Because the outcome has not yet occurred. Okay, simple. So this is the retrospective. You see, we go backward. You see, we retrograde. You see, we look backward. We look back in time. And the ideal retrospective study is the case control study. You see, exposure and outcome or disease, E and D relationship. You see, again, in all my lecture, I will stress upon this relation and how to relate all studies to this relation, to this slide, E and D relationship. Okay, so we start with the outcome. Yes, breast cancer and no breast cancer, two groups. And then we go back to investigate the possible risk factors. Right? Simple? Like, for example, diabetic food and diabetic with no diabetic food. So diabetic with diabetic food and diabetic. So we are searching for what? For the risk factors of diabetic food. So it is simple. The case control study is simple to do. But suppose we select the control and the cases in a scientific way. So this is a good example of the retrospective. This is an ideal retrospective study, by the way. Okay, this is a reverse. You see, prospective study, it looks forward. So it means that we start with the exposure and end up with the outcome in terms of the incidence of complication, incidence of whatever we are interested in. Okay, this is very important. So this an example of forward directionality or prospective is cohort studies and the clinical trial. Both cohort studies are, even clinical trial is a prospective study. Yes, it is. What is the difference between cohort and the clinical? The only difference will be that, as I told you, is that this is an observational study and this is an experimental study. What does it mean further? It means that there is an assignment here of exposure, assignment of subject to certain exposure. We give them drug, but here we do nothing. We just observe. We select a group of smoker and a group of non-smoker, and both of them were followed up. So we observe. But here, there is what is called the assignment. So when I ask you what is the characteristic, the main characteristic of clinical trial, you will tell me assignment. Assignment is the main characteristics of intervention studies, because we assign. The exposure is given by us, but it is the same exposure and the outcome. You see, this is very important. Again, look at this cross-section study, case control study, and the cohort study. Let us start by case control, by cross-section study, for which we start by the exposure and outcome at the same point in time. You see, cross-section study. Start here. Okay, E and D. E and D. You see, relationship. So this is the diagram of the cross-section study. We have a sample of the population and then we survey. It's a survey, actually. All surveys are cross-section studies, by the way. Yeah, any survey is a cross-section study. So we identify those with disease, and then the rest will be without the disease. For example, a group of 100, 20 will be with disease, and the 80 will be with no disease. So the prevalence will be 20%. out of the total, right? Because when we estimate the prevalence, it's a number of cases of the prevalent cases. Prevalent cases means old and the new cases divided by the age of population of at risk. Who is the population at risk? What is the population at risk for diabetes, for example? This is very important because so as not to get confused. What is the population at risk? Usually the denominator is the population at risk for estimation of the incidence or prevalence for any study. It's either as a new cases divide population by population at risk, it will give you the incidence. Old and the new cases divided by the population at risk will give you the prevalence. So what is the population at risk for diabetes, for example? Someone may say obese, someone may say with history of hypertension, with history of diabetes, stress, something, whatever. No, the answer is this is incorrect. Why? Because these are the population with high risk, not the population at risk. But what is the population at risk? The whole population, all of us is liable to get diabetes, right? So the population at risk will be all the whole population. What is the population at risk for breast cancer? The whole females over the age of 20, for example. This is a population at risk. Okay, what is the population at risk for prostate cancer, for example? All males over 40 years of age. These are just examples, you see, but just to know what is the meaning of population at risk. So we can stop here after you estimate the prevalence, just stop here. But what about if you have an association, for example, a prevalence of hypertension among children and its association with obesity? It means that you have a hypothesis now, which is investigation of a certain association. So you will go further to see the possible factor, associated factor. For example, for diabetes, you see obesity here, whether obesity, the proportion of obesity among non-disease and the proportion of obesity among disease. If the proportion of obesity, for example, among diabetic is higher than the proportion among non-diabetic, it means that there is a significant association between obesity and diabetes. This is the way, but don't say risk factor. In cross-section study, we don't actually identify risk factor. We identify associated factor. But risk factors in what? Risk factors usually in case control study, as we said before. Okay, simple. This is an example. For example, you see prevalence of metabolic abnormalities and the association with obesity among Saudi college students. You see, so how many objectives do we have here? 2 objectives in the title, and it's better to give to put your objectives in the title. The title should reflect the objectives of your study. You see, prevalence or estimation of the prevalence of metabolic, and the second objective will be to investigate the association of metabolic abnormalities with obesity among Saudi college students. You see. And don't do research except if you have a question. This is very important. You must have a good question that needs a good answer. If you have this question, start your study. If you don't have, there is no need to do a study, right? This is very important. So now me and my colleagues, Dr. Roueli and Professor Alwan and Professor Muhammad Roueli, we're interested to see why students in our university here, King Saud ibn Abdulaziz University, are obese. And I used to pray Dhuhr prayer there, and I discovered that many are obese. So we intended to see the prevalence of metabolic abnormalities and the association with obesity among those students. Okay. This study is just I'm showing it to you just to know that the word prevalence is not necessary for prevalence of disease. It could be a prevalence of positive attitude or a prevalence of the level of knowledge, a high level of knowledge, for example, or practices or whatever. So this is a prevalence study, but investigating the awareness and the attitude and the practice related to swine influenza pandemic. This study was done by us also during the pandemic of H1N1. Okay, so this is just to know that it's a prevalence, not necessarily the prevalence of a condition or this, it's a prevalence of attitude, awareness, or whatever, right? So what are the disadvantages of cross-section study? As I told you before, the lack of temporal relation between exposure and outcome. There is no guarantee that the exposure preceded the outcome to say that the causal association is guaranteed. This is a problem, actually. That's a weak design in terms of causation. Some people say that it's a weak design. No, it is not a weak design. You have to complete. It's a weak زي ما بيقول ايه لا تقربوا الصلاة. لا هنا it's a weak in terms of causation only, but it is the only study. It's a unique study for estimation of the prevalence of any condition or disease in the community. There is no such a study estimating the prevalence except a cross-sectional study. It's very important, but it's a weak as a causation design. To assess the causation, it's a weak design. We can't guarantee that the smoking preceded cancer. We can't guarantee that obesity preceded diabetes. You see, the temporal sequence of exposure and effect may be difficult. And why? Simply because we started exposure and the outcome at the same point in time. Okay? So usually don't know when the disease occurred. Okay. Let us shift to a case. Any table which contains in the title of the table prevalence of so and so, it's a cross-section study. Okay, simple. Now we'll shift to the case control study. Case control study is an ideal retrospective study. It is a hospital-based study design. Hospital-based, why? Because you start by cases. For rare cases, it is ideal for rare cases or rare diseases. Why? Because those diseases are available in your own ward as a specialist. So you can go to your patient, whether, for example, fracture of the hip, for example, breast cancer or whatever, rheumatoid arthritis patient, something like that. Don't search for them in the community, but go directly to your ward and select them, and then get a control group matched with them and conduct your study. It's very simple. That's why it doesn't take time. You see, because it's a hospital-based study. You have your own patient. This is very important. You see our case control study. Start by the outcome. See, it's a retrospective. Start by the outcome, and then for a breast cancer and non-breast cancer, diabetic foot and diabetes with no diabetic foot, right? So the case is having the disease and the control is free from the disease under study. It is not free from all diseases. It's just free from the disease. And for example, diabetic foot, those are diabetic, but with no diabetic foot, but they are still diabetic, right? But they are free from the diabetic foot. This is the meaning of free from the disease. They are not free from all diseases. This is very important. And you go backward to identify the exposure. What is the exposure? Exposure is the risk factors. Okay, possible risk factors for a certain disease. You do matching for cases and controls. This is very important, so as to make them similar. Matching makes them similar as much as we can, you see. But you will see later in by the end of this lecture that randomization is the only way that guarantees that both groups are in under study are the same, similar in everything by randomization. Without randomization, we can't be sure, we can't guarantee the similarity of the groups, but at least by matching, we will be able to make them much similar. So case control studies. So disease with cases and the control with no disease under study, and we go backwards. So backwards, this is the diagram for how to draw the design of a case control. So select cases and select a control matched with the cases. Okay, this is very important. And then search for risk factors here and risk factors here. If the risk factors here are higher than the risk factor, the proportion is higher among cases than among control. This means what? This means that they are, there is most probably this factor is a risk factor for disease. Okay. So this is the way. That's why, by the way, when you present a case control study, for sure you are interested because the aim is to identify the possible risk factor or a certain risk factor under interest in your study. So in all your tables, the proportion of the risk factor must be there. This is very important. In a prevalence study, so as it is a prevalence study, so the prevalence of your condition must be there, even with association with sex, with gender, with educational level, with lifestyle, with whatever, with comorbidities and so on. There must be at all through the tables, the prevalence figures must be there. This is very important. This is a fatal mistake that many of the researchers do not know this fact. In a prevalence study, tables must have the prevalence figures. In incidence study, the tables or graph for sure. Tables must have the incidence figure. And in risk factors, like in case controls, in clinical trial, it's an incidence. It's a cohort study. So it is an incidence study. So all tables and the graph must be for incidence. When you draw a graph, even it's the bar graph, you show incidence of the outcome, incidence of outcome. In the prevalence study, prevalence of the outcome. This is very important. In a case control study, proportion of the risk factor, not any. Why I'm saying that? I'm saying that because usually the researchers do not know whether to make the percentage, the total percent, to estimate the percentage in the table horizontally or vertically. This is a fatal mistake. Whenever I receive a paper as an editor to assess, and I see the tables are not well structured, it means I realize that this is still a junior researcher and needs assistance. Why? Because the percentage direction is not correct. You see, he doesn't know that the prevalence figures must be there, or the incidence figure must be there, or the proportion of risk factors must be there. This will be allowed by only knowing what direction to give you the prevalence. If the direction is horizontal, it will give you, for example, the prevalence. If you make it, for example, by mistake vertical, the prevalence will disappear. And the same for incidence and for the risk factor. That's why we are doing a webinar or a training course about the association and the causation, maybe in September, inshallah. It will be online. So you can follow for more details about that. Okay. So usually in any study design, we have two questions. The first question, the first question. اللي هو the hypothesis question, whether there is an association between exposure and outcome or not. The second question is, if there is an association, what is the strength of this association? What is the size of this association? And this size of the association or strength of association is estimated by odds ratio or relative risk. In cross-section study, in case control study, in cohort study, in clinical trials, in every study design, either odds ratio or relative risk. This is very important. For example, for case control study, it's a odds ratio, because the relative risk is only for cohort studies and for clinical trials. Okay, but odds ratio, it can be estimated for all designs: cross-section study, case control study, cohort study, clinical trial, whatever. You see, this is very important. We will discuss this later even. But let us first have, for example, we have 200 cases of coronary artery disease and 400 cases of normal subjects as a control. Someone may ask me, why 200 and 400? Why not 200 and 200? This is because the sample size estimation was 600. And we have only 200 cases. So we have to satisfy the sample size required by the AREST, which is 400. You see, it's very important. Suppose you have your sample size estimation for case and control is 120, and you have only 40. Like in a case control study for breast cancer, the newly diagnosed cancer at that time were only 40. So we took the 40 and the 80 as a control, normal subject, normal females. You see, to satisfy the sample. Otherwise, the power of the study will be affected. And someone may ask me, what is the meaning of power of the study? It needs explanation. It will be discussed later in other courses. But anyway, that's the power of the study is the ability to reject the null hypothesis when it is false. Suppose, for example, usually in any of the studies, we have a hypothesis, E and D relationship. The null hypothesis says that there is no association between exposure and outcome, between obesity and hypertension, between obesity and diabetes, between smoking and cancer. There is no. So the null hypothesis for smoking and cancer, that there is no association. And then we apply the study and we do the appropriate statistics. And after that, we see by statistics that there is an association. So we have to reject the null hypothesis. We say that the null hypothesis is rejected and the alternative hypothesis is accepted, which is saying that there is an association between exposure and outcome. This is very important. In any of the study design, there is what is called null hypothesis and alternative hypothesis. This is a hypothesis testing. If we have sufficient time, we could speak more about this. But anyway, I think by the end of this lecture, we'll speak about it. Okay. So let us have 200 and 400 and ask for exposure, which is smoking. 112 are smokers and 88 non-smokers. Among control, 176 and 224 are non-smokers. So how to estimate the odds ratio? The odds ratio, don't bother yourself. It is the odds of smoking among cases divided by the odds of smoking among control. What is the odds of smoking among cases? It's A divided by C. This table is the magic table. You see, this is A, B, C, D. It's 2 by 2 table. It's 2 by 2 table. If I speak about the 2 by 2 table, I can speak up to till tomorrow. You see, without stoppage. Why? Because this, you can merge all study designs and biostatistics and everything is by using this 2 by 2 table. You see, that's why I made training about 2x2 table, maybe later in September also. So you see A, B, C, D. So we can, the odds for cases, odds of smoking is A divided by C. And for control, it's B divided by D. So when you divide the odd by the odd, it will be across like this, AD divided by BC. You see, like this. So AD divided by BC. This is the odds ratio, odds ratio. What is the meaning of odds ratio? What is the meaning of this? What is the interpretation? So in any study like this, it's easy. And even in a cross-section study, we could calculate the odds ratio. This gives you the strength of association, the strength of association. Okay, so it's one, suppose it is 5, for example, 5. What is the meaning of 5 for odds ratio? Someone may say, smokers are 5 times more likely to develop coronary artery disease as compared to non-smokers. I can say that this is a good interpretation, but incorrect one. Why? Because you need to know that we haven't started by smokers and non-smokers. We started by cases and control. So the interpretation must start by cases also. So I can say cases with coronary artery disease are 5 times more likely to be smokers than the control group. Okay? 5 times more likely to be smokers as compared to control group. Okay, so in case control study, we must start by cases. And believe me, many of the researchers do not know this fact, that interpretation differs. If you say smokers are 5 times, it is incorrect completely, because there might be smokers are 12 times more likely or 30 times more likely to contract coronary artery disease than non-smokers. But at the same time, cases are 5 times more likely to be smokers. This is different. This figure is different from this. So take care. In a prospective study, we will say, because we go in this direction, we start by smokers and non-smokers, and we wait for the coronary artery disease as outcome among smokers and among. In this case, we will estimate what is called the incidence, and then estimate relative risk. And in relative risk, the interpretation will be different. Don't bother yourself now, but just to know that we start with cases in interpreting the odds ratio in case control study. This is very important. So the interpretation will be the odds of exposure for cases are 1.62 times the odds of exposure for control. Or another interpretation, those with coronary artery disease are 1.62 times more likely to be smokers than those without coronary artery disease, as we agreed upon. Or, moreover, a third interpretation, subtract 1 from the odds ratio and give the others. You see, those with coronary artery disease are 62% more likely to be smokers than those without coronary artery disease. Simple? Okay. I don't know whether you follow me or some got lost. Is it okay, Dr. Youssef?
There is some question, but we will ask it at the end of the presentation. Go ahead, Prof.
Okay, but we will end not yet, huh?
Yeah, 40 minutes more, I think.
Okay, no problem. Okay.
Go ahead, thanks.
I'm afraid they got tired ولا حاجة, huh? Is it okay?
This is the 3rd day, so it is hard to grasp, but with the time, maybe and repetition, they will.
Okay.
It will be grasped.
Okay.
Thank you.
You're welcome. Okay, so now what is the interpretation? Just to know that if the odds ratio is 1, suppose the odds ratio is 1, what does it mean? It means simply that there is no association between exposure and outcome. Okay, but if it is more than 1, it means that it might, more than one, sorry, here, it means that it might be a risk factor. Smoking might be a risk factor for coronary artery disease. But what about if it is less than 1? Sometimes the odds ratio is 0.6, for example. So it means what? If it is significant, it means that this risk, it might be a protective factor. Like when we studied, for example, a patient with congestive heart failure and the mortality in hospital mortality with beta blockers, we discover that those who are under beta blockers, the mortality among them is less, significantly less than those without who were not under a beta blocker. It means what? And the odds ratio was 0.6. It means what? It means that beta blocker was a protective, significant protective factor against in-hospital mortality for patients with congestive heart failure. Okay, so it can be -1 and can be +1 and can be 1. Again, another question is that if the odds ratio is 2, does it mean that there is significant association? It is not necessarily. It is not necessarily. Why? Because sometimes it is 2 but not significant, 2 but not significant, 2 but significant. It depends upon what? It depends upon so many factors, like the sample size, for example, and the populations from which the sample was taken. This is very important. Yani if suppose in a study, for example, of 20 subjects, for example, the odds ratio was 2, and the p-value was high, very high, not significant, and the 95% confidence interval is very important. This is the parameter of the population. I need you to know that in research, our interest is not just to estimate, to see the parameters in our sample. Our interest is usually in the population from which the sample has got, but because we are not able to study the whole population, what is the mean of study population? Study all diabetic, for example, all patients with diabetic foot, for example, all pregnant females, all school children, something like that, all patients with hypertension. These are the studies, these are examples of the study population, right? So our aim is to infer to the population. It's not in our sample. When I do a study on 40 patients with breast cancer, this is not my aim. The aim actually is the whole breast cancer cases in Saudi Arabia. But because I can't do that study on all, I do it on a 40 subject. But I have to make an inferential statistics so as to reflect, for example, the chi-square is, for example, the X bar, which is the mean sample is so and so. What is the mu? What is the mean for the population? The standard deviation is so and so in the sample. What is the sigma in the population? This is very important. So this the odds ratio in our sample is 2. What is the odds ratio in the population? This is very important. Of course, although it is 2, but when we repeat our study of 20 for in 100 times from the same population, every time we select a sample of 20 and we conduct our study, what we will end up with different odds ratios. It's different. Every study 100 odds ratio that ranged from 0.5 to 7.5. It means what? It means that it contains a value of 1. You see, 0.5 up to 7.7 contains a value of 1. So as it, and we agree that the value of 1 for odds ratio means that there is no association. It means that there is no association. That's why p-value is not significant. What about here? 50 sample of 50, and we applied it, we conducted it 100 times. What about the odds ratio? In the population, in all the 100 samples, it means this is the odds ratio for the population. It ranged from 0.9 to 4.6. Again, it contains a value of 1. It passes through the value of 1. it means that it is not significant. What about here? It's the same 2, you see, 2, 2, 2. But here it is very significant association between E and D. Why? Because there is no 1 in the confidence interval, 95% confidence interval. I know that 95 and the 99, all these will be described in another training workshops, inshallah, yani in details. But just to know that that they are, and nearly all journals now do not accept these odds ratio without corresponding confidence interval, or prevalence without the corresponding confidence, or incidence without the corresponding any parameter. Sample parameter needs a population parameter to be presented in your paper. This is very important, okay? Selecting control, this is very important. For each case, how many control we get? Either 2, 1 or 1 to 1, or 1 to 2, or 1 to 3, or 1 to 4. As I told you, why? To satisfy the required sample size. But up to 1 to 4, don't to make it 1 to 5. It will not work, and it will not be accepted even by any of the journals, okay? Either 1 to 1, 1 to 2, 1 to 3. Why? To increase the power of the study. Because, you know, as you know, when you work with a small sample size, you will not be able to reject the null hypothesis. That's a problem. Many of the studies were published with no significant association, not because there is no, actually there is an association, but you couldn't detect. Why? Because of your sample size, which is small. Okay. This is an example of a simple example of a risk of a case control study. You see, one of my students now, Salim Al-Fifi, he is a big consultant now in pulmonology in the National Guard. And he was a student at the summer school, and he asked me that to make a study about the diabetic foot. So which study to finalize during the summer? They attend the research summer school for only 5 or 6 weeks. And the time allocated for collection of data is only 2 weeks. So he can't do maybe a cross-section study. Maybe he was not able even to do a prospective study that needs time, or clinical trial, or whatever. So the best one, which is in a short time, is the case control study. So I selected this study for him. Risk factors. So when it is risk factor, it means case control study for sure. Huh? Risk factors for, if you go through this, if you go through this, you will find that the study says that the objective of this study is to identify the risk factors of diabetic foot in Central Saudi Arabia. So we selected 50 diabetic foot and 50 patients, and another 50 diabetic with no diabetic foot. And we put the possible risk factors to compare with. And usually when you study the risk factors in any of your study, it's simple to put patient characteristics and disease characteristics and the outcome characteristics. It's very simple. If you apply it in any of your studies, it's very easy. Usually we rely on patient characteristics in terms of age, sex, smoking habits, lifestyle, something like that. You see, educational level, whatever, social class, and then patient characteristics. If you are studying diabetic, for example, so the age of onset, type of diabetes, treatment modalities, for example, then complications, for example, something like that, and the outcome in terms of diabetic amputation or something like that. You see, easy, huh? So now it's easy to put the variables of your study needed for your study. It's very easy, as these are considered as if they are international variables, as sometimes they name them, okay? So examples of case control study, Dolce study on smoking and lung cancer. And as I told you, up till now, there is no an intervention study to prove this association. thalidomide by pregnant women with congenital defects of their offsprings, and also oral contraceptives and thromboembolism among the females, you see, especially those above the 35 years of age. That's why we don't recommend the oral contraceptives for females over 35, especially if they are smokers. Okay. What are the advantages of case control? Quick, easy to complete, cost effective, for sure. Most efficient design for rare diseases. For rare disease, do case control study. And one of the objectives of this lecture, as I was asked to, is to present how to select the appropriate research design. So this is how to apply. For rare disease, select a case control study. For rare exposure, select a cohort study. Usually it requires smaller study population. See, we worked with only 50 diabetic foot. We worked with only 40 breast cancer cases. And all these studies were published in good journals. This advantage is uncertainty of exposure disease time relationship. You see, uncertainty. You see, we can't guarantee of E&D relationship. We can't guarantee of the temporality of relationship. We don't guarantee of that, that exposure precedes the outcome. We don't know whether exposure with smoking precedes coronary artery disease. This is very important. The same like in cross-section study. Inability to provide a direct estimate of risk, because the direct estimate, the non-direct estimate is the relative risk, but we only estimate odds ratio. Odds ratio is the cousin of the relative risk. You see, when you don't know how to estimate the relative risk, you can do the odds ratio. But the direct estimate usually is because the direct estimate relative risk rely usually upon the incidence of outcome, but we don't have outcome here. The outcome is already there. We started with it, right? Not sufficient for studying rare exposure. As I told you, rare exposures are exercised or investigated by a cohort study. Subject to biases, for sure. Recall bias and selection bias. Why? What is the meaning of recall bias? Recall bias is usually when, for example, ask the subject about the smoking. So for some, smoking is considered as a stigma, as embarrassing behavior. So some people will deny that they are smokers. So this will make what is called the misclassification in your table. They are considered as non-smokers, although they are. If you ask for dietary fat intake, some may say no, although they are, they love dietary fat intake, right? They love fat consumption in their food, so, but they deny. So this will distort the odds ratio. Instead of having no relation, you will end up in your study with a significant relationship, although there is no. Right, this is very important. Or if there is an association, then you may end by no association. Selection bias, especially for the control, because in the control group we must have some musts, 3 musts actually. The control must represent the population, so the risk factor available in the control group must be the same as it is in the population. For example, if the smoking among the control group is 10%, it must be 10% in the population. It has to be, the control must be selected from the same population from which we got the cases. This is very important. A third must is the timing. Don't have cases for now and control from 10 years ago, because the health system is different and everything, and lifestyle was different. You see, as you know, this is so many of the case control studies are rejected because of the selection bias. You see, they don't know how to select the control. This is a problem, but I'm sure we have no sufficient time for everything. But anyway, cohort studies, okay? Cohort study is the reverse. We start by exposure and end with the case. You see our case cohort study and the clinical trials. Cohort study and the clinical trial. Okay, we start by exposure, smokers and non-smokers, and then follow them up till we reach the incidence of coronary or whatever incidence of the condition of interest. You see, it must be incidence, not prevalence. Why? Because it's a new. It is not there. We are waiting for this incidence to occur. In both, that's why in clinical trials we study the same. It is as if we write a cohort study. When you write a clinical trial, it is the same like a cohort, but with assignment. See, as I told you before. What is a cohort? The word cohort is a people with or whatever sample with the same characteristics. A cohort of smokers, a cohort of obese subjects, something like that. ماشي? So we start with a factor, exposure group, and non-exposure group. Okay, exposure group and non-exposure group. So smoker and non-smoker, we are waiting for the coronary artery disease to occur here as incident. And here among non-exposure, non-smoker, we are waiting again for incidence of coronary artery disease. If the incidence of coronary artery disease is higher among smokers than among non-smokers, this may say that the smokers are risk factors for coronary artery disease. And also the incidence, suppose the incidence here is 10% and the incidence here is 2%. When you divide 10% by 2% among non-exposure, it will give you the value of 5. What is 5? 5 is the relative risk. What does it mean? It means that smokers are 5 times more likely to develop or contract coronary artery disease as compared to non-smokers. Simple. You see? What shall we present in our table? We shall present the incidence of coronary artery disease, not the proportion of smoking here or here. No, it has to be the incidence of coronary artery disease. This is our interest. This is the aim of the study, is to estimate the incidence. So the table must show the figures of the incidence. This is very important. Don't show them other figures. A general consideration, this slide is very important, very important. Why? Because in cohort studies, both the cohorts are free of the disease. Both cohorts are free of the disease. Yani smoker and non-smoker, but both of them are free from coronary. For example, we are waiting for the coronary to occur. We must be sure that they are free. Otherwise, there might be an error, selection bias. We have what is called selection bias and the information bias. If we have time, we can discuss the types of biases and you see. Anyway, both groups should be equally susceptible to disease. Don't start with a group of immunized against measles, of children immunized against measles, and say, I'm going to wait for mortality from measles. They are immunized already. So they have to be susceptible for the condition you are waiting for. They must be comparable, the same like in matching for case control study. Also, diagnostic criteria for outcome and disease must be defined well. Operational definition of variables is very important. Operational definition. Diabetic, what is the meaning of diabetic? Hearing impaired, what is the definition of hearing impairment? This is very important. All these, near miss, what is the definition of near miss? Everything in your study must be gestational diabetes. What is the meaning? On what definition you relied? You applied your study based on what definition? Because sometimes there are lots of definitions. Okay, this is a prospective study started by exposed smokers, non-smokers, and then the outcome coronary and the coronary, for example. This is the direction. Why? Because it is a prospective study. Let us now, after we discover that there is an association between those, and we estimated the incidence, we started like this. You see, this is very important. So there is no total here. The total is here. It's very important. When you draw the table, we will know whether you understand what you are doing or not. And there is no need to put table here, because these are two groups, two distinct groups. How can you make them together in total? Every group rely upon itself. We estimate the incidence for the group, which is 112 divided by this. And here we estimate the incidence among non-smokers, which is 88 divided by this. Clear? And then we divide the incidence by the incidence. Incidence among smoker divided by the incidence of coronary artery disease. We were waiting for the incidence. It will give you 1.38. What is the meaning of this? Suppose it is 10. What is the meaning of 10? It means simply it's a cohort study. So we started by exposure. So we have to say, now we can say that smokers are 10 times more likely to develop or contract coronary artery disease as compared to non-smokers. In case control study, we started by cases, but here we started by exposure. Simple, exposure and disease association. Simple. So this is the interpretation of risk of developing coronary. The risk of developing coronary is 38% higher than among smokers than non-smokers. Again, relative risk, if it is 1, it means no association. If it is more than 1, it may be a risk factor. If it is less than 1, it may be a protective factor. The same like an odds ratio. You see, someone may say, "What I see that some people are heavy smokers. They do not develop cancer or coronary artery disease." Why? Simply because it's a risk factor. It is not a cause. It's a risk factor. And risk factor means, what is the definition of risk factor? Risk factor is usually a factor that is more associated with a certain disease than with a subject without the disease. That's it. Simple. It's an association, but not causation. You see, so risk factor. That's why smoking usually is named as a causative factor for cancer. A causative factor, risk factor, but not a cause. It's a causative risk. Suppose now the exposed group smokers, 10% of them develop a coronary artery disease. And non-smokers even develop coronary, but at less incidence. You see, 6%. So it means that the excess is this part for smokers, excess in coronary artery disease. How can we estimate this part? We may say incidence among exposed or among smokers minus incidence among non-exposed or non-smoker divided all by incidence among exposed. Very simple. This is the attributable risk. Yani we estimate the relative risk and the attributable risk. In what percentage the cancer developed among smokers is attributable to smoking. You see, you can go to those with cancer and who are smokers and say your cancer was 90% of your cancer is actually could be attributed to your habit of smoking. This is the issue. You see, this is the meaning of attributable risk. So suppose now a table like this, can you estimate the relative risk? Suppose this, I told you that this is a prospective study. So it means that we have a group of smokers and non-smokers. What about this? Someone may say, why you did the total here? No, there is no need for this total. It's just an example. Okay. So this is lung cancer. What is the incidence among smokers? It's 70 divided by 7,000. What is the incidence of cancer among non-smokers? It's 3 divided by 3. What is the relative risk? It's this incidence divided by this incidence. It will give you ما فيش أي answer عندكم؟ Okay. Anyway, because of the time, I can't wait. So it's incidence among smokers, and then incidence among non-smokers, 1 per 1,000, and here 10 per 1,000 divided by 1 per 1,000 gives you a relative risk of 10. What does it mean? It means that smokers are 10 times more likely to contract cancer lung. What about attributable risk? It is incidence among smokers minus the incidence among non-smokers divided by the incidence of among smokers. So 10 minus 1 divided by 10 multiplied by 100, it will give you 90%. What is the meaning of 90%? 90% of cases of lung cancer among smokers, you have to say among smokers, not among all population, among smokers are attributed to their habit of smoking. And we used to estimate this figure in our papers also, right? This is an example of a prospective study, you see. Prospective study of early and late outcomes of extremely low birth weight. This took 9 years to finalize this study, by the way. Okay, because it took 3 years of extreme low birth weight infants, and then follow up for 6 years. So it took 9 years to do. Predictors of patient satisfaction also, it's the same also. This we were aiming to see the outcome of patient satisfaction in terms we followed the patient from being in the front desk in the ER till being seen by a doctor. You see, so it was a follow-up in our hospital here, and it is published in Emergency Medicine Journal, one of the BMJ journal. This is, you see, a retrospective. A study cohort could be a retrospective also. Could start here, you see. It means that the outcome has already occurred, right? Outcome has already occurred. So we go in the record and we know that, like for example, pregnancy and life and the low birth weight, they are available in the obstetric records, right? We have the age of the pregnant female and we have the low birth weight among those, right? So we will select, not to select the outcome. No, we have to start with the exposure. We select teenage pregnant women, for example, and normal age pregnant women, and then search for the incidence of low birth weight here and the incidence of low birth weight here. Don't start by low birth weight, otherwise it will be a case control study. We start by exposure. Simple? I hope it is. Cesarean section in high community, for example, you see, we did a good study about cesarean section and outcomes in terms of fetal and maternal outcome. Many of the outcomes, it was a very nice study from records, you see. That's why it is a retrospective cohort study, you see, of 5,000 cesarean section.
Prof. Mustafa, can you repeat the difference between case control and retrospective cohort study, because we have around 6 or 7 questions about it. What is different between these two?
Yeah, sure. In case control study, you go directly to outcome, because it's a case control. So we start by cases. So outcome, we can go to the low birth weight here and no low birth weight here. You see, and see the age of the women during pregnancy here among those with low birth weight and among those with normal birth weight, right? But in the cohort study, we do the reverse. We start by exposure. We, for example, pregnant females of less than 20 years of age, and a control group or a comparison group of pregnant females of the normal age. And then we see the incidence of low birth weight here and the incidence of low birth weight among those. Clear? This is the difference. Okay, examples of prospective study like Framingham study and nurses health study. We followed the Framingham study that started in US since 1948 up till now, and the fourth generation. And we did lots of studies about coronary artery disease and the risk factors and the relative risk. And so we based on the Framingham study, and there is a special program software we used to buy the software to do our study, to finalize our studies that had been published. Cohort study, what is the strengths? It can be find out incidence rate and risk, more than one disease related to single exposure, correct. It can establish cause and effect relationship. Now we can guarantee that exposure A preceded the outcome. We have no problem with this. Good when exposure is rare, right? Very simple. It minimizes selection and information bias because it's not a retrospective one. Okay, so it's easy now to minimize the selection and the information bias. Weaknesses, loss to follow-up. That's the main weakness, is that some of your study subjects drop out. Or to often require sample size to compensate for the dropout. Ineffective for rare disease, but it is for rare exposure. For rare disease, you can go to a case control study. Long time to complete, and the time is money, so it is expensive. And the last thing is an ethical issues. What is the ethical issue? Is it ethical to start with a group of smokers and we follow them up waiting for the complications to occur instead of conducting a program to allow them help and help them to quit smoking? It's strange. You see, you are waiting for complication. But anyway, you are not the one who asked them to smoke. You are not the one who assigned them to smoke. It is not an assigned study, as in case of clinical trial. So you need the approval of the IRB, that's it, to investigate the level of harm for those groups. What happened? Okay, no problem for this. Experimental studies, just a few minutes for experimental. It's the same. The investigator can control the exposure. This is very important. It's because of the random assignment. Randomization is very good, is an excellent phenomena for studying. You see, randomization allows that everybody has an equal chance to be selected either in the experimental group or in the comparison group. You see, equal study. This is the meaning, simple meaning. But if we study randomization, it needs a day, a full day, to study the types of randomization and the way we randomize it. There are many different ways, but simply it is this is the definition. Clinical trials are the most well known. These are the gold standard. You see, some universities, like McMaster, for example, they rely only upon the conclusions of clinical trials. This is the ultimate step in testing causal hypothesis, in testing E and D relationship. This is the ultimate goal. We started from a case report, case series, ecological study, case cross-section study, case control study, prospective study, retrospective cohort, and then this is the ultimate one. Many of the studies were done in observational design and with conclusions that have changed by the clinical trial. Like for example, hormone replacement therapy among females, for example, was good and was recommended by observation study. But when they applied clinical trial on hormone replacement therapy, it showed no benefit. So it is not being prescribed anymore now. Many of the observation studies recommended a modest amount of alcohol to protect yourself from contracting coronary artery disease. Many of the studies, not here yet, but outside in the West. But now after clinical trials, it's proved nonsense. You see, this is very, and many others. So this is, you see, this diagram is the same like the diagram of cohort study, but it allows assignment and random assignment. This is the main thing. The exposure is done by ourselves, is assigned by us. So treatment group and a placebo group or comparison group. You see, this is very important. The impact of basic life support. Where I was asked to do a research to assess the impact of the BLS here in our National Guard on the attitude of healthcare workers towards cardiopulmonary resuscitation, CVR. And it was done and published in good journal. This is a quasi-experimental design, one of the experimental design. Quasi-experimental. Quasi means it is an experimental study, but with a control group, but without a randomization, something like that. Yeah, because we have 3 groups of experiments, one with no control group and with no randomization. The other group, which is quasi, is with control group but with no randomization. The third group is a true experimental group. It has both a control group or comparison group and randomization. Randomization allows you to generalize your conclusion, and the control group allows you to minimize the threats of confounders, like, for example, history, like maturation, regression, mortality, many of the confounders. It needs maybe 1 or 2 hours to explain, but anyway, just to know. This is the intervention study. This is a comparison. Both are patient, but we give drug here and no drug here or placebo and see the outcome. So those patients who receive inner treatment in a control comparison group yet respond as if they had received real treatment are demonstrating what? Do you have answer? You have answer for this? No one? I don't know whether there is answer or no. Question and the answer here.
Someone, Dana Al-Yusuf answered placebo.
Okay,
Placebo effect.
This one? This one you mean?
Yeah, the placebo effect. She answered.
Great. The placebo is correct. Okay, so we have 3 types of intervention studies. We have randomized control trial, we have field trials, as I told you, like in vaccinations, and the community trials, as I told you. Clinical trial on patient like this, and the outcome in terms of recovery, readmission, something like that. So randomized RCT is the gold standard, but the problem is that for ethical reasons, it couldn't be applied for some of the studies, like in case of smoking and the cancer, for example. You can't apply RCT. This is a hierarchy of the intervention. Reference population, and then you select a group. These are potential participants. Older age may be, for example, will not be fit for our study. For example, they are excluded. We have exclusion criteria. And then we invite the other. And we ask them to give an informed consent. This is very important. Some people will refuse to give the consent. We are left with those who give us the consent. So we randomize them into 2 arms, intervention group and the comparison group. And this is an example of a real study that was done to see whether early discharge or late discharge is better for MI patients, for myocardial infarction patients. So they started by 500 patients, and then those with old age with complication were excluded, and they were left with 179, and those refused to participate, and they ended with 80, 40 for early discharge and 40 for randomly assigned. They found that the outcome in terms of deaths, readmission, re-angina, something like that. And for sure, they found that the early discharge is better than late discharge. You see, preventive trials.
Prof, excuse me, Prof. You have 5 more minutes. Sorry
Okay.
for that.
No problem. But for preventive trials, as in vaccination, we are busy here in the Kmart with some trials on vaccination of MERS, COVID, for example. We give some vaccines and then some trials for drugs also as clinical trial. But for MERS, we are testing with Oxford University the protective effect and safety of the MERS-CoV vaccine. So this study was done also. It's a real study to see whether a vaccine for leishmaniasis, cutaneous leishmaniasis, you know, cutaneous leishmaniasis, it makes a disfigurement in the face and skin. Maybe you are young, so you haven't faced this problem. You haven't seen, but for older people, they must know this. You see, so it started by 1400 and then randomized 1300 into treatment vaccine or this with vaccine and those without vaccine or placebo. And they found that the relapse or the susceptibility to the leishmania was the same in both groups. That's why this vaccine was not distributed, was not recommended by the WHO anymore. Community trial, as I told you, suppose you have 2 villages, 2 communities with the high prevalence of parasitic infestation. They give drug and drug here, but applied intervention, education intervention for this group to see the impact of intervention in terms of re-infestation and the incidence of parasitic infestation and malnutrition and something. We used to do many of the studies in Egyptian villages on like this. Which of the following is unique to the experimental research study? Any answer? No answer? Assignment.
Assignment. There is answer assignment.
Abdulaziz, yes, correct. Excellent. Assignment is a unique. We intend to investigate if the use of ice is more effective than an exercise program in treating a particular type of physical injury. ده في الجماعة الفيزيوثيرابيست عندنا two groups. واحد هنديله ice and another group هنديله ايه physical exercise. Right? Design most appropriate for investigating this phenomenon, this problem is what? Experimental or observational? Which one?
Experimental, the answer.
Correct, correct. Experimental is the answer, correct. طيب, look at this. An investigator intends to establish if there is a relationship between the levels of atmospheric lead, and the learning defects and cognitive defects. We used to do many of the studies on atmospheric lead. In children, the design most appropriate for investigating this phenomena is which one?
The answer observational.
Not it is not ethical to do to expose the children to atmospheric lead. So, but you can get a child or children who are already in a residing beside a factory that exposes that lead. Okay. So randomized control trial is a gold standard, as I told you before. Disadvantage, very expensive, not appropriate to answer certain questions, like in case of smoking. There are certain ethics for explanation and informed consent and feasibility and the compliance with study, many, right? And the masking, we have what is called single blind and double blind and triple blind. Single blind, when the participant only doesn't know for which group he applies, whether to experimental or to control group. Double blind, when both the participant and the observer do not know about the study. Third, blind, when even the investigator, the PI, doesn't know which one, whether this individual is related to the experimental group or to a, because everything is put in an envelope, closed envelope. You see, this is very important. So the problem here, and we will finish by this problem, okay? A researcher is studying the effect of a new drug on healing of ulcers. Patients are assigned randomly. You see, when you see assigned randomly, you will know that it is a clinical trial, assigned experimental study by a physician who treats them to receive either the standard treatment or the new drug for ulcers. Patients are informed that they are being studied. For sure, they must be informed, right? But they don't know which treatment they are getting. The measure of scale of rate of healing here is the number of days until the ulcer is completely healed. Clear? This is the stem of the question. Clear? Okay. Let us now have this. What is the type of this study? Which one? No answer?
Waiting for them.
True.
True.
Correct.
True.
Correct.
Supplemental.
True. Correct. Excellent. Okay. The second question is, the independent variable is above, in the above study was. Independent means the exposure, because the dependent variable is the outcome. So the exposure variable in this study is what? This might be a difficult question.
One answer: new drug, new drug,
New
new
drug.
drug,
What
new
else?
drug, new
What
treatment,
else?
type of treatment, type of treatment,
Type of treatment. New drug.
healing time.
Healing, healing must be an outcome, right? Okay. It is either the new drug or the type of treatment. Which is correct? What do you think? New drug or the type of treatment? Variable. Look at this. We are asking about variable. New drug is not a variable. It's a category under the variable. We have treatment, type of treatment, and under this type of treatment, we have either the new drug or the placebo. Two categories, right? This is very important, or conventional drug. But this is a category and not a variable. This is a variable, right? Okay. What about the dependent variable, which is the outcome variable? Any answer?
Still waiting. Ulcer. Type of treatment.
Ulcer, the condition itself is the outcome.
Rate of healing. Rate of healing. Most of them.
كده معقول. Rate of healing. خلينا أشوف بقى بنفسي. Rate of healing, correct. صح. Rate of healing, excellent. Okay. This study is double blind or single blind or not blind at all? Give me
single
answer.
blinded, single blinded, single blinded.
Single, correct, excellent. Okay, I have done now and waiting for any question. Thank you very much indeed.
Thank you, Prof. Abu Fatouh, for a very comprehensive talk about study design. We can talk hours and hours about study design, and we just cover just the tip of this topic. I remember I attended one of your courses when I was medical student or intern 1 decade ago. So
with me?
Yeah, with you in National Guard.
It's a pleasure.
Thanks.
Okay.
So we have multiple questions, and we will try to go through all of them, and we will see if there is anyone who wants to ask a question directly. So we'll go through the question and answer section. You already answered the difference between retrospective cohort and case control. So we'll go now to other question. There is a question about, is it possible to conduct prevalence study by retrospective study?
Yeah, you can. Yes.
Okay. So
It depends upon your objective. If the objective is to estimate a prevalence, it's a prevalence.
okay,
Yeah.
great. Can we say that intervention is included in prospective study while intervention is absent in retrospective studies?
Say it again, please.
In the prospective study, that means we need to do intervention, but in the retrospective study, we cannot do intervention.
In prospective study, we don't do intervention. In clinical trial, we do. In intervention studies.
Thank you.
But in retrospective or prospective, we don't do intervention. In prospective, we start with the outcome and wait for, we start with the exposure and wait for the outcome. But in retrospective, we have both exposure and outcome available in the records.
Yes.
Okay, that's the difference.
Is it observational or experimental study?
Observational. Observational. Yeah. Prospective cohort is an observation study.
In case of studying adherence of using medication for a certain disease, which kind of study design? It could be anything.
Using medication?
Yeah, adherence to using medication.
Adherence, it's a cross-section study.
Okay.
So as you estimate the prevalence of adherence or the pattern of adherence, it's يعني from the objective you can decide whether it is a cross-sectional or, but for example, impact of adherence, for example, something else. Suppose you compare between adherent or not adherent to the medication. It's another study design, right?
Yeah, and with the outcome of the adherence. So
if you are outcome, so you select a group from the record, for example, who adhered to a certain drug and another group with no adherence and see the outcome. In this case, it's a retrospective cohort study. It differs.
Yeah.
Because your aim is to see the difference in outcome. But if you just study the prevalence of adherence, it's a cross-section study, right?
Right. It's about all the aim of your study or your question.
Yeah, sure.
If we do a retrospective observational study, starting with the cases, but without having a control group, is this called retrospective descriptive study?
No, in case control study, you must have a control group. This is very important. You see, but in prospective study, you can compare with the population, right? Yeah, this is a good question, by the way. In cohort study, in prospective cohort study, you can compare your outcome by the outcome available in the population. There is no need to have a comparison group. You can, but in case control, it's a case control. That's from its name. It needs a cases and control.
Okay. How to match case and controls?
The controls with certain criteria, as I described, with 3 must from the same population in the same typing, with the same proportion of risk factors as in the population, right?
And in the same real, how we can match case and controls? How we can do that? Like
this is a good question also, because you see, suppose you are not interested to in studying the age as a case as a risk factor, for example, in your study, so you can match for age. If you are not interested in gender, you can match for gender. If you are not interested, for example, in number of children, you can adjust for number of children. You can adjust for parity, for gravidity. You see, yani if I have time, I can show you how you adjust. For example, if you have 30 years age, if a female with cancer breast, search for another 30. Or if it is 1 to 1 or 2, if it is 1 to 2, for example, 230 females is normal breast. You see this, and we can say sometimes with plus or minus 2 years, because sometimes you search for 30 years you can't find. So it's 28, okay, 32, okay, 31, okay, no problem, something like that.
Okay, thanks.
But for the factor of under study, for example, what about lipid, for example, or obesity and the cancer breast, for example, and you have a group of breast cancer and a group of normal female. Don't match for obesity because the risk factor under study is obesity. So don't match for obesity, for body composition at all. Okay.
Great. You already answered this question, but we'll repeat it. Could cross-sectional studies be a retrospective study?
Yeah, it could be.
Okay. So we will have one question from the participant. Direct question. Can we unmute Hisham Luqman? Hisham Luqman?
Yeah.
Or Aisha Al-Idan? Or Hisham, تفضل. Ask your question. Aisha, can you unmute Aisha Al-Idan?
Yes, Aisha.
Yes, Assalamu alaikum. First of all, I'd like to thank you, Prof. Mustafa, and all panelists. My question is, if I'm doing a study that's aiming to assess the prevalence in addition to CAB, which is knowledge, attitude, and practice of toward something, and then I want to relate it to the associated factors, is it good to title it as prevalence, knowledge, attitude, and practice, or just be knowledge, attitude, and practice? The second part, would it be good if I did odds for this study, as it's a cross-sectional study, if I calculated the odds?
Yeah, you can calculate the odds for a cross-sectional study. The same like what we estimated in case control study. And also you can name it in the title as a prevalence or KAB study of so and so and the associate factor. That's it.
Okay, so I can associate it with the factors that are being studied. I mean, like, I can't say this is risk factor, but associated factors. Because I've done the proposal.
Excellent. Don't say risk factors. It's associated factors.
Edit it. Okay, thank you so much.
You're welcome.
Continue with the question and answer from the question answer section. If I put a target outcome, but that outcome that occurred was different, what shall I do if I also was interested with the unexpected result and I want to highlight it and go further with it? I think it's too deep question. What do you think, Prof?
Yeah, maybe this happens with clinical trials, for example, when using certain drugs or certain interventions with some adverse events that are unlikely. That's why it is needed in clinical trial to address the previous adverse events in the previous reports, in previous studies, if we have. And sometimes we can stop the clinical trial if the adverse events are not acceptable. You see, many of the studies are stopped because, like, for example, even in COVID-19, many of for example, the clinical trial for hydroxychloroquine stopped when they discover that it has no benefit, something like that.
Yes. Thanks. Can you go through what is the difference between associated risk factor in cross-section study and risk factors in case control studies? Is there
it's the meaning is nearly the same, but it's weaker. You see, in cross-section study, it's weaker than case control study. That's why we say associated factors. It has no meaning. It's just associated, but it helps us to generate further hypotheses. That's why when you do, for example, we can do, for example, prospective study or cohort study without relying upon previous cross-section study and the case control study on the same condition, so as to be sure that there is a hypothesis to start with. Don't go by yourself and do cohort study for something that hasn't been studied before. You see, by a cross-sectional. But cross-section study helps us to do more rigorous studies. That's it. That's the idea. You see, that's why it is only associated factor. Okay.
So we had multiple questions about the sample size. Do we need to estimate sample size for all study design and to the proposal?
Yeah, you need, except for case report and the case series for sure. But sample size estimation is very important. It's very easy if you go to a biostatistician or even to OpenAB, for example, AB Info which is free of charge software with the WHO. It is available online. You see, you can estimate immediately the
sample size.
The sample size, because you see, without estimation of the sample size, you can't reject the null hypothesis. You will not be able to reject the null hypothesis. Like a sample size, it's like for example, in a court trial. In a court trial, you have an innocent person and you have a guilty person. But guilty person is there, and you can't prove that he is guilty because you have no sufficient evidences against him. The same in our research. If you have no sufficient sample size, you will not be able to reject the null hypothesis. The null hypothesis in the court trial says that this person is innocent. You see, although he is guilty, but there is no proof. It's the same, the sample size. The null hypothesis is incorrect, is false, but you can't reject. You need to accept that there is no association because simply you have a small sample size. This is very important.
Thanks, Prof. What is different between correlation and odds ratio? Is there a difference or it is the same?
Yes, odds ratio is usually done for categorical variable, but the correlation is for numerical variable, and there is a course for correlation and association and the causation in 17th of September, inshallah. It will be online.
Can you
association, correlation, and the causation. We will cover all these things.
Thanks, Prof. Can you unmute Muna Al-Fadil?
Yeah.
Muna, can you ask your question? Okay, can you unmute Muhammad Rajab Naji? Okay, we can continue with our question here, question and answer section. Muhammad? Okay. When I would to know about prevalence certain complication of disease, is that a cross-sectional or descriptive? When I'm talking about
prevalence is a cross-section. Prevalence is a cross-section. Incidence is a cohort.
Okay, and would you please elaborate more about study design variants? For instance, case crossover study, nested case control, or case cohort? It is. This is other course. I think
it needs another course. Yes.
Yeah.
Yes. Nested, usually nested case control study. We do it in here in the National Guard. When you do, for example, for biobanking, you do a cohort study or a prospective cohort study, and then when you discover something, for example, outcome, for example, we study the populations, for example, over time. And when we discover an outcome, for example, for diabetes, for example, some diabetics, so we go to the lab and we select the samples of those diabetic and another sample of blood and urine for non-diabetics. You see, and see the difference in the genetic constitution, because we keep the sample to study the genetic constitution to see whether those diabetic develop diabetes because they are different from non-diabetic in their genetic constitution. Something this is considered as a nested case control study. So after we do a prospective study, we conduct nested case control, diabetic, which are cases, and non-diabetic, and to go back to the genetic constitutions from the lab samples. Yeah, that's clear?
Hopefully it will be clear.
Okay.
We will take more 15 minutes more because we have a lot of questions, if you don't mind, Prof. And before that, just remind you, all of you, tomorrow will be, and after tomorrow we'll have ethical aspect in clinical relation, in clinical research with Prof. Abdul Gabba. Tomorrow is a break. Continue with the question. If we will study the association, i.e. the odds ratio and cross-sectional study, is it no longer descriptive study, but rather analytic study? We already answered that.
No, if you are going to estimate an odds ratio, it's an association. It means that you have a hypothesis.
Yes.
Association between two factors, because odds ratio measures the strength of association between two variables, exposure variable and an outcome variable. So how come to be a descriptive? It's an analytic study.
If we have odds ratio of 1, does that mean a failure of research?
No, exactly no. 1 is the same like 2, like 3, if all of these are not significant. You see?
It's an addition for the research or the...
yeah, if negative results are the same, strong and useful like positive results. If the p-value is not significant, doesn't mean that your study is failure. Usually junior researchers are interested to have p-value of less than 5. Although it is not this issue, our interest is to know the truth. You see, if you tell me that exercise has no value for health, exercise has no value. If you tell me that for example, whatever, for example, green tea is not associated with is not significantly associated with coronary artery disease, fine. I will not comply to green tea for nothing, right? That's it.
Again, Prof, so many questions about what is different between retrospective cohort study and case control study. Still they didn't grasp the idea.
Yeah.
What is different?
In case control study, you start with cases, with the outcome and its control. But in retrospective cohort, because it is cohort, you start with the exposure and then go to the outcome. This is the difference. You see the direction of your point of starting. This is that differs. You see, this is very important. Start with the outcome in case of case control study. Start with exposure in the cohort study, whether it is retrospective or prospective. I know that many of the researchers got confused by this, and I used to receive many of the proposals that write retrospective cohort, although they wrote in the description case control study, and I used to correct this for them and ask them to rewrite again.
Can you unmute Rufaida Arfaj? Rufaida? All right. Or Fatima Musa? Fatima? Go ahead, you can ask your question if you have any question.
There is another question here, Lamia, right?
Lamia,
how would you interpret the results of an odds ratio where the p-value shows statistical significance and the confidence interval is wide, but still significant? It has no value of 1, so it is significant, no problem. Okay. Although as biostatisticians, we understand the value of a wide interval and a narrow interval, we can get something from that. But so as it is significant, the p-value is significant, the odds ratio must be significant also. The confidence interval must be significant as well. Okay.
The association, correlation, effectiveness of certain measures and treatments. Can we do all of them as a case control study or not?
Yes, you can. Why not? Why not? If you have, for example, but correlation is correlation. By the way, correlation doesn't mean causation, and association doesn't mean causation. You see, causation is something else. We can describe it as I told you, in the next course.
Okay. Again, question about sample size. Is there a certain number, or it's different from study to study? Is 100 case for retrospective study is enough, or we...
No, it depends. You see, just to know, this is very important question. The sample size is not equal for the whole studies. Because it depends on, for example, if I'm studying the prevalence of diabetes, for example, I have to rely on the prevalence of diabetes in a previous study to estimate the sample size based on this prevalence in the previous study. If I am studying the incidence of so and so of complication, I have to rely on the incidence of such a complication in a previous study. If I'm studying the risk factors of diabetic foot, for example, I have to rely upon the risk factors of the proportion of risk factors of diabetic foot in previous studies. So every study has its design, has its own sample size estimation, has its own equation. Okay.
Can we
Good
extract?
question.
It was asked maybe 2 or 3 times. Can we extract odd ratio from relative risk and vice versa or not?
No, it's difficult because this rely upon incidence, upon cohort. But odds ratio can be estimated, as I told you, for cross-section study, for case control study, and for cohort studies. You can, for all, estimate the odds ratio, but relative risk is only for cohort study and for sure clinical trial. You see, you can't estimate relative risk for example, if you estimate odds ratio for cross-section study, there is no need to estimate the relative risk, and you can't estimate the relative risk because there is no incidence. In case control studies, there is no incidence, so you can't estimate a relative risk. How can you estimate a relative risk? Okay.
Okay. Can students conduct a clinical trials or not? It is.
Sorry?
Can students conduct a clinical trial by themselves without supervision or not?
Students do clinical trials?
Yeah.
Without supervision? No, in clinical trials, it needs usually supervision. It needs monitoring. That's why we have monitoring unit, and it has to be registered first. And then every now and then the monitoring unit will assess you. They will send someone to assess you and show you, and ask you whether you have adverse events or not, or something like that. In cohort study, it's okay, but in clinical trial, no, it's an assignment. So you have to be monitored all the time.
What is the benefit of randomization?
The benefit is of randomization. As I told you, in case control study, you do matching so as to make the 2 groups similar. And in cohort, you allow for the 2 groups, exposed and non-exposed group, to be in comparison to each other. Comparative, I mean. The same for clinical trials, to allow the 2 groups being similar. Otherwise, it will eliminate the effect or reduce the effect of confounders. Yani you need, if you have time, I would allow for showing you the effect of confounding. Confounding effect of some variables is very important. That's why you have to include them in your study. But in clinical trial, you started and you are sure that both groups are similar in everything, in age and sex and whatever. You see, this is very important. But if they are not similar, you can attribute that the experimental group showed benefit from the drug, not because of the drug, but simply because they were younger. You see, and the other group were older and they died, for example, or they didn't respond to treatment. So age will act as a confounding factor, you see, with a confounding effect. This is an example, you see.
Okay. For triple blind study, if the investigator doesn't know what type of treatment or intervention that given to the patient, how we can calculate the relative risk?
The relative risk, after a biostatistician will open the code, because every patient is coded by a code 32A for something like that. But even the PI doesn't know about this code and the meaning of this code. And when by the end of the study, the biostatistician will open the codes and everybody will know everything, but not before the end of the study.
Thank you, Prof. Abdul Fatouh. Just because we don't have enough time to answer all of the questions, Can we have your slide and send it to the participants, or we cannot? And what type, how they can register in the upcoming courses that you conduct?
Just to show you that I can let me show you now how to come up with these slides. If we
your screen is on freeze.
Really? You can't show now?
You cannot see anything, only your slides.
Why you closed everything?
No. Still, you are sharing your slides, but not your screen.
Yeah. So I have to share it, huh?
Yeah. Share your screen, please, Prof.
Okay, I will share the screen. How to share a screen now?
First, you need to stop sharing the screen, then share the screen, the whole screen, not the slide only, the whole screen.
Okay, I share.
First screen, the
share
green,
screen. Like this.
Then,
share screen. Where is the screen? This one. Okay. Now you see?
Yeah. Thanks.
You see? Great. Okay. I can now give you here. You go to Amazon and you will find a good book about research made easy. It contains all the slides and all questions and answers. This one. You see this?
Yeah, the first one, the research methods.
The search one, the search book. Okay. This is a very nice book. It can help you much for those who are interested to refer back to this lecture and to other lectures.
And how can they register in the upcoming courses you have in the National Guard?
It's easy now. It is online. You can contact. Just go to the website of the KMARC, King Abdullah International Medical Research Center, and the Twitter also of King Abdullah International Medical Research Center. Every now and then we are putting, for example, scientific writing and publishing is there in the website. Research methodology course was there, and we just finalized it for 3 days last week. Tuesday and Wednesday and Thursday. We just finalized it last week. And in September 3rd, we will have the scientific writing. And in September 17, we will have the association, causation, and correlation. Okay. And any other courses will be available in the website, as I told you, and in the Twitter also. Just to go to the website, write King Abdullah International Medical Research Center or KMARC, KIMRC, on the internet, and you will find. For example, you can go to the KMARC. This is a KMARC. KMARC innovations, everything you see.
And they will find the course and the data.
Everything, everything, and the courses and everything. Proposal submission and everything related to the KMARC is there.
Great.
Okay? Very simple. And LinkedIn also, you see. Twitter also, you see. If you go to Twitter, you will find
the announcement.
Everything.
Okay. Thank you, Prof. Mustafa, for accepting our invitation.
Anytime. I hope you enjoyed this course, this lecture, and best of luck. I personally enjoyed being with you. Thank you very much.
Thank you for sharing your expertise and knowledge. Just a reminder for all participants that tomorrow is a break, and after tomorrow, Prof. Al-Gabba will present ethical aspect in clinical research. It's important to fill out the feedback that you receive after the finishing of everyday course or session. Thank you again, all of you, and thanks, Prof.
And please don't forget to greet Professor Hoga. He's a colleague and a friend for years.
Yeah, inshallah, I will.
Best of luck.
Thanks, bro.
Thank you very much. Bye-bye.